kia koutou I tēnei wā. Ka mahi tuatahi me te mana whenua o tēnei rohi o ngai tuahuriri, tēnā koutou, tēnā koutou. Ka mahi tua rua, ngā hōmahi, I roto I te rōpū o hauora, nau mai haere mai ki tēnei rōpū, ki tēnei kura o tākou whakaihu waka. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. On a cold, chilly night, it's so amazing to see your warm smiles out here as we get to acknowledge our colleague and my personal ENT surgeon. So I'm hoping for a family and friends discount after tonight. To something that I think is very peculiar in the university setting, and that is this inaugural professorial lecture. To me, it's like it's Phil's last exam. So we're all grading, yeah? It's both an opportunity to actually, for many of us, to really understand our colleague's journey and why we're here tonight, but really it is a celebration of an incredible achievement. It is very rare to be able to have clinical academics in our field. At the moment in health and in tertiary education, we're in really, really challenging times. And despite that, we have these amazing unicorns who not only are outstanding in their clinical field, but also outstanding in the academic field and give us the opportunity to go from to connect the science and the clinical practice. And I've had the real benefit of actually being at the receiving end of Phil, so on both the academic and the clinical side, and I know why we're all here to celebrate him this evening. But I know that Phil is not here alone and he didn't get here by himself. I want to especially acknowledge Amanda, his wife, for her tolerance and patience, because that's what it takes to support someone to get to this space and place, and also his sons that are here with us this evening. We have two, Sam and Isaac, and also the wider whānau. We want to acknowledge you because this is definitely a collective effort, and it's with much excitement that we invite you into this place. We've heard a lot about you, but we're really excited to enjoy this evening with you alongside your whānau and friends. And so with much further ado, because you didn't come here, well, we've got a bit of a curtain raiser tonight, and the curtain raiser is actually Professor Tim Eglinton, who is the head of Department of Surgery, who is going to formally now introduce Phil. Kia ora, Tim.
Kia ora, Suze, and tēnā koutou katoa, ka Tim Eglinton aho. Phil, Amanda, family, gives me great pleasure to introduce Professor Philip Bird for his inaugural professorial lecture. Tiny spaces, huge impact, managing inner ear disease. So this is the first time I've had the opportunity to do this actually as for one of our department as HOD, as Suze mentioned, and look, to be honest, I couldn't be doing it for a more deserving candidate or a better guy. Phil is a clinical professor in the Department of Surgery and Critical Care, and he's one of New Zealand's leading otologists. He graduated MBCHB from Otago in 1987, I think I was in third form, Phil. He became a Fellow of the Royal Australasian College of Surgeons in 1995, and he completed an advanced fellowship training in otology and neurotology at the University of Miami Ear Institute. I didn't actually realise Phil had trained in Miami until preparing this, and it kind of all makes sense now. It's that sort of uncanny resemblance to Don Johnson of Miami Vice. And I wonder where it came from. But anyway, thankfully Phil didn't stay in Miami, sitting in his budgie smugglers, sipping mojitos. And we were very, very fortunate that he made the decision to come back here to Christchurch. Because since returning to Christchurch, Phil has built an outstanding clinical and academic career in complex ear disease, cochlear implantation, neurotology, and lateral skull-base surgery. He's been central to the Southern Cochlear Implant Programme, and his research has made major contributions to cochlear implant outcomes. equity of access, prevention of inner ear injury, and drug delivery to the inner ear. Now, as a colorectal surgeon, to be honest, I don't understand anything about any of that, and I'm actually really looking forward to Phil hopefully explaining that to us this evening. But where I particularly got to know Phil was through his teaching leadership. He's coordinated undergraduate ENT teaching here in Christchurch for more than 2 decades now, and it really has been a very significant commitment and contribution. But I think what struck me was when his colleague Scott Stevenson tragically passed away, that Phil's generosity really stood out. He stepped up selflessly and without fuss to support the students, the program and his colleagues, no questions asked. That generosity is a theme, in fact, and his colleagues describe Phil as sort of something of a yes man, in the best sense of the word. Although I'm told that this once extended to agreeing to be on call, only for people to discover that when they needed to contact him, he was actually in Fiji. So perhaps Phil's commitment is immense, but not always sort of geographically local. Anyway, but no, seriously, Phil, he is a wonderfully thoughtful clinician, a generous colleague, and someone who brings real curiosity and precision to the smallest and most intricate spaces in the human body. And so I think it's very fitting that tonight's lecture focuses on those tiny spaces and huge impacts. So please join me in welcoming Professor Phil Bird.
Kei aku nui, kei aku rahi, ina hau e whā, kua kau, mai nei, e tēnei ahi, tēnā koutou. Kei te mihi atu au ki ngā tangata whenua, nai tahu. I tupu aku ki te tai tokiro, e te taha o maunga tanawhamonga, mea awa nui hoki. Ke autotahi toku kainga i nai nei. Tēnā koutou katoa. Thanks very much for the very kind introduction. I'd like to sort of do an extended Pākehā mihi to talk a little bit about where I come from. And as many of you here know, I'm from the far north, and I'm very proud of that. And if you get me talking about it, I won't shut up. But briefly, I come from a little town called Kaitaia. I grew up on a farm just south of there. Kaitaia is it's probably about 5,000 people, and it's unique in that it's sitting. Is this actually working? Yes, it is. It sits between both the west and east coast in the far north of Northland. And in my mihi, my mother's family come from just north of Victoria Valley, just north of the Maunga Tanawha range, and my father's family come from Awanui, which is a little town just north of Kaitaia, and the Awanui River runs through Kaitaia and out to the harbour there, and it quite recently flooded. Fortunately, they'd done quite a lot of work to mitigate that. Kaitaia was a great place to grow up, pretty laid-back sort of place, and I can see my friend Scott out there who also grew up there. Being a guy growing up there, there's amazing non-verbal communication. So you could pass someone on the street and that means, I think you're a pretty good guy because I've acknowledged you. I've had an okay day, how was yours? Without having to say anything. I'm a very proud graduate of Kaitaia College, the local high school. I did pretty well academically, but it was an interesting place to go to school. It was, you were either brainy or you weren't. And if you're brainy, you didn't need to work because you were brainy. And if you weren't brainy, there wasn't any point working. So I got a bit of a shock when I went to university and had to get stuck into things. The area's got amazing beaches and a beautiful climate. This is an amazing beach, east and just south of Kaitaia. This is called Taupo Bay, and it's a view from our little whare. This is what you can achieve if you don't work full-time for the university. I was really into sport. This is me at probably the age about 15, opening the bowling for the local cricket team, playing the Kaitaia men's team on an artificial pitch. And I'm still a cricket tragic. I was a bit sad that well, I was really pleased for them, but I was sad I wasn't there, that two of my sons recently watched New Zealand play England in London, so never mind. My other big passion was rugby, and being fairly small and white was a bit of a challenge, but I really loved my time playing. This is, I'm holding the ball, looking like the ball boy. I'm not looking at the camera because I was acutely embarrassed, so I felt I didn't belong there anyway. But it was sitting in the front row with my Kaitaia mates and got chucked the ball by the cameraman, by the photographer. And so I'm looking really, really awkward because I was not the captain. They thought I might be the captain. This team was actually coached by Tim's father-in-law, Tak Waka. I remember being really annoyed that he shifted me from anywhere I might get the ball from kickoffs because I was too skinny. I thought, I can do this. But looking at the picture again, I can see why he did it. We actually came second in that tournament to an Auckland team containing one Sean Fitzpatrick. But anyway, it was great times. I've got a whole bunch of thank yous just to quickly do before I forget them. So I've had some fantastic role models in ORL colleagues over the years. I started off my training in Wellington, and one of my colleagues, Graham Webster, who was a fantastic surgeon and just a really decent guy, and you can be both. I've had some great colleagues in Christchurch when I was training. Scott Stevenson, who's already been mentioned, the late Scott Stevenson, Rob Allison, who's here tonight. Both sort of taught me that you can achieve excellence in surgery if you work at it. My boss, unfortunately, also passed away in Miami, Tom Balcony, who I learned a lot about managing difficult patients and cochlear implantation. He was the first person I ever saw fire a patient, which shocked me. But he walked up to quite a difficult person and said, "Just as you have every right to be seen by another doctor, I have every right not to treat you. Here are 3 people who can treat you in this city. Goodbye." Which is a very non-Kiwi way of doing things, but anyway. People in Christchurch, academic surgeons. Frank Frizzell is a great inspiration to, I think, just anyone who does any academic surgery, and Tim's been fantastic to work with as well. Lutz and Suze, who you'll hear from, we have heard from and will hear from tonight, have been just a wonderful leadership in the university, and I really appreciate your friendship and all the work that you do. Lutz, I've known you since we were junior doctors in Wellington, as well as Shelley and Amanda. I won't go tell a whole story, but she tells a very good story of when you were a medical registrar and got called to see a delusional World War II veteran who was having delusions about the Second World War, and they called Lutz in to see him. You can imagine the rest. A lot of sort of proper scientists that I've worked with over the years, who've done research with, some of whom are here. Thank you so much. Really nice to see, and I'm honoured to see Peter and Haruna up there. So thanks very much for coming, and Greg as well. Fantastic. We've had a lot of fun and have relied on your guidance. Also, a whole bunch of registrars, fellows and students that I've done research with over the years. I hope I've been helpful. I hope I pulled my weight. The anaesthetists I've worked with, often doing clinical research, saying, it won't actually make the case longer if we hook this patient up to a whole lot of wiring and start the case late and finish it late. It'll be fine, don't worry. And they've gone along with me, which has been really, really nice of them. I didn't tell the administrators at St George's that, but it's a charity. It's fine. My PA in private, Tanya, who's been amazing for many years now, does lots and lots of academic stuff. No cheque in the mail from the University of Otago, but she's helped me immensely with all sorts of things over the years and puts up with me cancelling things at the last minute and other such annoying things. I'd like to thank my sons who put up with a dad who's not always there over the years. I'd like to thank two really amazing women in my life. That's my mum, Bev. I've got a lot of accolades for my teaching over the years, but excuse me. I don't deserve to be in the same room as her from a teaching perspective. So Mum taught maths at Kaitaia College for over 40 years, and so like 3 generations of kids. Generations in Kaitaia are a little bit shorter than they are in Pendleton. I'm teaching people who have succeeded really well academically, who are there, so she'd be teaching kids in February in Kaitaia, hot as hell. They weren't really interested a lot of the time, but she got them interested, and she's a real legend up there. I'm only well known in that area because of my mum. And I had a good friend of mine the other day when I was up north at a cricket reunion, actually, still gushing about how he's retired now, about how she managed to get him through school C maths so he could get his apprenticeship. And that's teaching. I haven't got a picture of the other person I'm going to thank, but because she's right here. My amazing wife, Amanda, who has put up with me for well over 3 decades. Really reminded me what's important in life, and has also been a really great supporter of all of her 4 boys. She's sacrificed a hell of a lot for me over the years, and so thanks very much, darling. Right, I better get on and talk about some research. So this is the photo that was taken for this talk. Prior to doing so, Amanda wanted me to sort of present, not look like a boring old man, and I said, well, I am a boring old man, it's fine. But she wanted me to maybe have something to do with what I do, sort of hold something or something like that. And I thought, well, maybe I could get my photo taken by a microscope, because I spent my whole life just about eating my breakfast with a microscope. But that wasn't allowed. But I've got a life-size replica of what I do, about what this talk's about. Just staring you right in the face. That. So that was given to me by Kiran Dulku, who was a fellow of mine a few years ago, as a really lovely gift. That's how big the inner ear is. Not very big at all. So at the front is the cochlea or cochlea, the organ of hearing, and there's another 5 organs of balance. So there are 3 semicircular canals, superior, lateral and posterior, and in here in the vestibule of the inner ear there are 2 otolithic organs. So they're tiny, tiny things that supply our brains with information about acceleration and gravity, which way is up. Whereas the 3 semicircular canals, they sense movement, and they align with our eyes to give us a thing called a vestibulo-ocular reflex, so that when we move we can maintain a stable visual field. So it's a fairly important thing for anyone or any animal to be able to hunt or avoid being hunted. It's a very basic part of physiology. I'm going to talk a little bit about the inner ear, of course. So as you can see, it's very small. There's 6 different organs within that tiny space, and it's surrounded by the most dense bone in the body. It's very inaccessible. You may have heard of ancient DNA. So people obtaining DNA on many 1,000-year-old specimens of humanoids or human species. The best source is the inner ear, because it's so inaccessible. But it makes it very difficult to investigate, to research and to treat. Inner ear symptoms, you think, oh, it's a bit of hearing loss, a bit of dizziness. It's a bit more than that. So it causes sensory type hearing loss or sensory neural hearing loss. Tinnitus, hyperacusis, that's when only slightly loud sounds are really, really irritating. distortion of sound, and if the sound's distorted, you can make it louder, but it doesn't make it clearer. You can have a blocked ear, you can have imbalance or disequilibrium, so it's a big falls risk if your inner ear's off kilter, and vertigo. Now vertigo, most of us may have had vertigo for a few seconds, turning around quickly. A lot of people in this room will have had a thing called BPPV, where you get vertigo for maybe 15 or 20 seconds. When you get it for hours, it causes awful nausea and vomiting, and it's revolting. And what's even worse is if you're getting it relatively regularly, you do not know when the next one's going to come. So I have patients with many ears disease who have a bucket and a towel in the back of their car so they can stagger out from work and just fold themselves into their back seat. They don't want to plan things because they don't know when their next attack is coming. It's really, really horrible. So they're really, really significant symptoms that you don't wish on anyone. I'm going to concentrate on hearing loss because although I have done some research on the vestibular part of the inner ear, we'll talk about hearing loss. It's a bit easier to understand. So hearing loss, it's our commonest disability, and it is really, really grossly underrated by the vast majority of people. And it's critical right throughout our lives. So at the start of our lives, small children need to be able to hear to develop speech and language. Later on, it's critical in education. It's massively important in being a human, in relationships and in mental health. And there's a well-known article in The Lancet citing it as the biggest or largest modifiable risk factor in dementia. So it's really important all the way, but really, really underrated. So for example, older people will say, oh, I'm just getting old. So they accept it. Or conversely, I don't want to look old by wearing his hearing aids. So as you heard, I've been involved in cochlear implantation since I came back from Miami. I need to quickly explain for probably quite a lot of people in this room about cochlear implantation. So it's when people don't have enough hearing basically to understand speech. And they've been around quite a long time, and there are two main groups. There are children born without enough hearing for hearing aids to enable them to understand speech, and there are adults who've had hearing and developed speech and then lost their hearing. The problem is it's expensive. Cost effective, but initially expensive. So a cochlear implant's not a hearing aid. It's a device that replaces the outer, middle and inner ear. It's not a cochlear transplant, as some people say. It's actually replacing the ear with an electronic device. There are a couple of bits to it. The outside bits here, so there's a microphone and a speech processor. So that turns the sound into an electronic signal, and it gets transmitted across the scalp to the implanted bit in here, where there's a receiver stimulator and there's an active electrode and a reference electrode. And the active electrode is placed inside the cochlea, and what it's doing is each individual little electrode has a small electrical field which stimulates a number of nerves. And they work because most people who lose their hearing in that way lose the hair cells and their supporting cells, but they've got neural elements that you can stimulate, and that's why they work. And they work very, very well. So there's been a number of themes of cochlear implant research. Firstly, cochlear implantation in New Zealand context. So when we started off, when I first started off doing cochlear implants in this country, there was zero funding for adults, nothing whatsoever. Then, and there were tiny numbers for children, not nearly enough. So we've had to build that up. When we formed our charitable trust, we had an initial meeting with the minister concerned. She had been briefed that they didn't work. We disabused her of that idea fairly quickly, but that's the sort of thing we faced early on. So to present some outcomes research showing how well people did is really, really important, both to get people referred, but also for funding streams. Another theme is paediatric cochlear implantation, especially based around the effect of universal hearing screening, which I'll talk about in a minute, and language outcomes. And there's some other things that I won't talk about tonight, but various surgical issues, unusual conditions, and after meningitis. So one of the specialties of the unit I worked in Miami was the ossified cochlea. So if you get meningitis, you get infection in your ear, it fills up with bone. It makes it rather difficult to get something in there. So it was a fantastic experience learning how to manage that. We try to prevent that now with early diagnosis, but... So paediatric cochlear implantation. So we did a series of papers looking at the effects of neonatal screening, both on the age of referral and implantation, and then later on with language outcomes. And then also for the kids we were implanting early who weren't doing so well, the effect of device use. What's neonatal screening? It was a lot of work, and it's great to see Peter here again. Thanks, Peter. Peter Thorne, who was instrumental in instituting this. I wasn't involved in this sort of stuff, but it's a lot of work and planning in order to institute universal screening. It's been really well supported by midwifery, which is fantastic, and it's a very effective screening program. And prior to universal screening, we probably picked up less than a third of kids. They had to actually have a risk factor for it. And, but unfortunately, the commonest cause is genetic non-syndromic. So there's absolutely no hint that this beautiful small child can't hear. And it's very important to diagnose these kids early to get hearing aids and/or cochlear implants, so that they can develop speech. So this is the effect in terms of both referral and implantation. So prior to screening, we were basically implanting these kids around about the age of 2. So we're really playing catch-up. These kids have not heard for 2 years prior. Afterwards, we're implanting most of them about the age of 1, or between 6 and 12 months, which has made a massive difference. How does that apply to language outcomes? Well, you can see on the box plot, and it's great to see John Pearson here, thanks, who gave us he gives us a lot of help with our stats and with our papers and research in general. Basically, number one is the pre-screening group, and group 2 is the post, and you can see the pre-screening group, they do improve over the years, but they never really reach normal language levels. Whereas our post-screening kids are achieving really good language just a couple of years after implantation. And that means if you're implanted, say, at the age of 1, your language skills, by the time you're getting to preschool, are doing really, really well, so you can really benefit from that. This is looking at both groups, looking at language scores versus the age of implantation. And there's a couple of things here. Basically, you can see that if you implant a kid before about the age of 18 months, maybe a little later, they do pretty well. But we've still got kids down here who, despite being implanted early, aren't doing that well. And why is that? What we looked at is device use. So the devices now have data logging on them. So we can, well, the audiologist can tell how many hours they're being used in noise and in speech. And we don't use it in a pejorative way, but we can measure how often the kids are actually wearing them. And it's well known that parents do underestimate how many hours their kids are wearing their implants, and hearing aids for that matter. And there are different ways of categorising that, but we used 8 hours per day as so-called consistent use. And that makes a difference. So in the title there, it says that is the outcome. So if they use consistently for the first, within the first couple of years, they do a lot better. So we've got kids who were obtaining consistent use within a year versus 2 years versus 3 years. And the results are quite stunning. And it's a real challenge for us to make sure that the whānau of that child has good support before we put the implant in. And we've also trying to make it our problem, not the parent's problem. Right, I'm going to talk briefly about the effects of middle ear surgery on the inner ear. So the middle ear, remember, is the eardrum, the little bones of hearing, the mastoid, and I do a lot more middle ear surgery than inner ear surgery, well, about the same probably. And we've got to remember that when you hear your auricular chain, the movement with sound is in nanometers, whereas I'm pretty careful, but I don't do surgery in nanometers. The auricular chain is actually pretty robust. It does absorb a lot of the energy, but there are risks. So and there's a lot of other risks. So there's noise of drills and things, the force to the chain. If you're actually opening into the inner ear and you suction the inner ear fluid, it doesn't like it so much. So we did some work measuring the extent of hearing loss and also the force generated, with a number of people in this room. And more recently, we've had some attempts at actually trying to test someone's hearing or their inner ear function while we're actually operating on them, which is a huge challenge. So, Grant and Nigel, wake up. There's some bones here. My orthopaedic colleagues. This is micro orthopaedics that we do. This is an operation called a stapedectomy. So there's a condition called otosclerosis, where some abnormal bone grows over the front of the stapes, the smallest bone in the body, which we can do surgery to occasionally to bypass by removing the superstructure of the stapes, that bit there, the sort of wishbone bit, and making a tiny hole through into the inner ear here, that's the vestibule of the inner ear, and then placing a prosthesis and to basically bypass the obstruction. And it's a fantastic little operation. To give you an idea of scale, the stapes is about the size of a hollowed out grain of rice. That little hole is about 0.8 of a millimetre in diameter. The piston diameter is about 0.6, and that length from here to here is about 4.5 millimetres. Use a laser, which makes it quite a lot of fun, and also reduces the amount of energy we put through things. So we looked at stapedectomy. This is some work with Melissa Babbage and Greg O'Byrne, along with Mike Bergend. This is just a single patient, and it's a bit hard to explain, but basically these are audiograms. Normally we only measure up to here. We don't measure these extended sort of dog whistle high frequencies, and most people get a really good improvement. So you're trying to join up those crosses with the triangles, and that patient, this is pre and post, will be absolutely thrilled with their massively improved hearing. But actually, if you measure these extended high frequencies, they're reduced in a lot of patients. And basically what we found is if we measured it early enough on, over 80% of people had evidence of those really extended high frequencies being reduced. And even after a year, it was still half of them. And that's despite people being really thrilled with their results and being able to join those two lines up in about 90% of patients. It could be a really good model to test protecting inner ear function. It may give us more information because just under 1% of people actually lose all their hearing during stapedectomy. There's a small but horrible risk, and it's awful for the person, and it's awful for the surgeon as well, to be honest. So it's something we can perhaps work on in the future. Measuring the force. This was a lot of fun. I see Mike over there, did a master's project with me. This is just a small part of it. We got the smallest available force sensor, and we were playing with cadavers and patients trying to work out what sort of forces we were imparting when we were pushing around on the auricular chain. So that's the sensor there, and there's a thing called a curved needle, this little thing at the end here, applied to the sensor, and did a bit of measuring. And it probably wasn't earth-shattering science, was it, Mike? But it was a lot of fun. My mother would be accusing me of showing off now, and probably hit me. But this is the task here was to, on a cadaver, move one of the little bones of hearing as little as possible to sense that it was moving. And Mike will be pleased he's not on the slide, but this is a fellow at the time, and that's some random consultant just showing the difference in force applied to get to that task. Finally, along this little theme, measuring hearing in real time during surgery. That is a huge challenge. Operating theatres are ridiculously noisy. They're electrically really, really noisy, as any audiologist will tell you trying to do testing in operating theatres. They're actually physically really noisy. My theatres are often a bit like a building site, complete with appropriate language. We have a lot of fun working together, but it makes testing hearing really, really difficult. And the other thing is that there's a delay in getting the signal when you're testing hearing, trying to test hearing live. And it needs to be real time so you can actually change what you do. And that's a massive challenge. We are nearly there. It's some work I've been doing with some colleagues in Perth. There's some audiologic scientists in Perth, which I need to re-kickstart actually. But we've been using a thing called ASSR to do the testing. And just a little example, this cholesteatoma is a type of middle ear disease that we do a lot of surgery for. It's like basically a ball of skin. And basically the threshold, that's bad. That's temporary loss of hearing during dissection. So that's working around the auricular chain, but then you see how it recovers. So just really interesting, but very, very early stage research. We've published the technique only at this stage. Right. Now, the third and you might be pleased final thing I'm going to talk about is drug delivery to the inner ear. So the inner ear is, as I said, very cloistered away, so it's hard to get drugs in there. There are three different ways. So systemically, so that's intravenous or oral drug in the bloodstream, but there's actually a barrier between the blood, just like there is with the brain, there's a barrier between the inner ear and the blood. So it's quite difficult to get it in there, and you deliver the medication to the whole body. There's intracochlear, so that's actually sticking a hole into the inner ear and delivering it directly. And that's fine if you're doing a cochlear implant, but otherwise it's pretty invasive and it carries risks of its own. And then the third way is so-called intratympanic, and that involves injecting the drug into the middle ear, so through the eardrum, filling up the middle ear and hoping that enough diffuses across a thing called the round window membrane into the cochlea to deliver it. There were quite a lot of animal models available, but what we did is to develop a human model. So what we'll be doing is, oops, wrong one, sorry, apologies. What I'm talking about doing, if I can see my dot anywhere, basically injecting across the eardrum, filling up the middle ear space, there it is, through here, filling that up and having it diffuse through into the cochlea that way. And there are lots of potential issues involved. So steroids are used in the treatment of both sensorineural hearing loss and Meniere's disease, and so we deliver that way by injecting them into the drum. And there have been animal studies done, mostly on guinea pigs, suggesting that you could achieve really high concentrations in the inner ear. But animals aren't like humans. Guinea pigs much smaller, the distances are smaller, the round windows not as thick. and they can actually diffuse across the bone. It's so thin in guinea pigs. So we developed a human model. So we used cochlear implant surgery to develop our model, and I did this in conjunction with Evan Begg, who I met with just a few minutes ago, so I have to mention him. And so what we did was we injected patients asleep, but we haven't done the surgery, injected, filled the ear up, set a stopwatch going, and then before we were going to enter into the cochlear implant, into the inner ear, we'd take a tiny amount of perilymph, the inner ear fluid, and then send it away for testing. And so we delivered it directly into the middle ear, but also used some low and high dose intravenous steroids and did the same fluid collection process. And this is from a publication, basically showing, although there's a very different concentrations across patients, orders of magnitude more gets into the inner ear if you deliver it directly. And the converse, as you can see, you can get very high doses in the plasma, so drifting around the person's body, but you still don't reach the same concentrations in the inner ear, even with high dose intravenous versus delivering it directly. This was a little embarrassing. So we published this, and then a German friend of mine and a couple of Americans took our data, which is great in the end, and worked out some more complicated pharmacokinetics, worked out the clearance, the rate at which the drugs get cleared out of the inner ear, which is actually really important too. And it showed the clearance half time was just under half an hour, which is not really long enough to be particularly effective for many conditions. And we repeated with another steroid, dexamethasone, same sort of results. So I'm now moving on to some really exciting stuff we're doing with a whole bunch of us throughout the country. So there's a whole lot of different things that you can potentially deliver to the inner ear, including steroids, as I've mentioned, sodium thiosulfate to prevent hearing loss in children having chemotherapy with cisplatin. And the latest thing is actually gene therapy for a uncommon, but about 1% of deaf children born deaf, a genetic problem, and they've actually introduced genes into the inner ear and obtained hearing, which is pretty amazing. So some work initially done in China, but also in Europe. And what we're trying to do is to improve delivery. We're not looking at particular drugs, lots of other people are doing that, but we're trying to improve delivery. So this is the TRIP program, and we're concentrating on intratympanic treatment and wanting to use ultrasound to improve our ability to force the drugs across the round window membrane and then into the cochlea. It's combined with some really clever photonic assessment, looking initially at the membrane itself and then possibly looking at substances just the other side of the membrane, which I won't concentrate on. And it's a pretty decent sized team. The top row are doing all the hard yards and the preclinical work under the fantastic leadership of Peter and Haruna in the back row there. And I'm very pleased and proud to be part of it. And the idea is that we will eventually have a delivery system that we can start trialling. So the idea is if we can, so what my earlier research has shown that yes, you can get it in here, but the length of the cochlea is such that diffusion alone won't spread it right round the inner ear or the cochlea itself. And so it needs a bit of an oomph. So you apply the drug there, but then you need to push it into the inner ear and along as far as possible to get a decent concentration. So there are lots of treatment of inner ear diseases that it may be that the drug is useful, but we just can't get enough of it in there. So it is really important. We're also using a sheep model which could be a bit awkward if we're presenting our work in Australia. We get a bit of a hard time. Sheep's very useful because it's a large size animal model. As I said before, guinea pigs are not wonderful. They don't really apply that well. Whereas the sheep, the length of the cochlea is about 2/3 of the length of a human one. The round window is very, very similar. There's been some fantastic work showing that. So it's quite exciting. And it's at an early stage, but this, I think those are my hands with the pink gloves on. And that's applying an ultrasound stimulus to the round window. And these are just some early safety studies that we've been doing. So there's a lot to go, but I'm really excited about it. I can see some people flagging, so I think that's probably time to leave. Thank you very much for your attention.
Tēnā koutou katoa, ko lo speka takuengua ko aho te manutaki o taku whaka iwi waka o te tainei. Thanks, that was fantastic. My name is Lord Speckert. I'm the honour of being the dean of this campus in this region. And I have made a few notes, Phil, but since you mentioned this patient at ICU, I might just mention that as you've worked out by now, so I did not train in the North Island, I trained in the Northern Hemisphere. I'm indeed from Germany, and I was very excited to get an offer in New Zealand. So my wife is New Zealander, and we had this offer to get to the Centre of Excellency at Masterton Hospital. And you can just imagine us flying across the world, arriving after several stopovers in Wellington, getting a rental car. They called it the Rumataka Hill. It felt more like the end of the world. Arriving at Masterton Hospital and just wondering, what have we done? And so I actually went inside the hospital. I felt some familiarity being in the sort of these neon-lit dark corridors at Masterton Hospital. It felt like, oh God, it felt more like The Shining, but still, it was there. And then that's where I met Phil for the first time, and Phil was incredibly friendly. He welcomed me to New Zealand, to Masterton Hospital, and this was in, God, was it 1989, 1991? It was a few years ago. And then, of course, as Phil mentioned, and I was working in ICU with Amanda, looking after this patient who was delirious. I remember this patient. I also remember I was very pleased for Amanda when she said she had this hot date with this exciting young surgeon. So it was very good. And then our third touch point is really Phil's, as you noticed in his presentation, his focus is always on the patient. He did acknowledge how much work other people did around him, but when Phil started at Christchurch Hospital, we sort of started at a similar time. The decision was that Phil's operating list was on a Friday, which actually meant, and Amanda is nodding, which actually meant that for I don't know how many years or decades, Phil did a post-surgery ward round every Saturday. And I quite frequently met him with his 3 boys and my 3 boys, somehow trying to negotiate these Saturdays ward rounds, which didn't fit well into family life. But you stuck to your values, you stuck to your principles, you kept focus on the patients, and yes, I think we've been working together also for about 30 years now, so very, very proud to welcome you as Professor of Otago. So fantastic working with you, Phil, and fantastic presentation. Welcome.
Thank you so much, Phil. We will ask you now to join us for refreshments out in the foyer, and Prof. Peterma will do a karakia on the kai just before we start that. if you can be upstanding, please.